have good data on that, but based on the stages that we see, I suspect it's much higher. And as you know, metastatic breast cancer is not curable, but it is often treatable for at least a number of years. And in countries that have more treatment options, we're actually having people live almost decades with metastatic breast cancer. So it has very different biologies depending on the features. So when you're rounding on advanced stage incurable breast cancer, I think about some major questions. So always ask yourself, where is the disease and how fast is it growing? And was the patient staged appropriately at the beginning? If they had multiple lymph nodes when they were first diagnosed, did they ever have a chest x-ray or a liver imaging or a CAT scan? Because sometimes you suspect that they may have had metastatic disease for quite a while, but at the time that you are finally seeing it. If they haven't been staged appropriately, then how do you know these haven't been there a long time and may be slowly growing? And that's important to think about because slowly growing lesions are not going to respond very well to chemotherapy. And if you're trying to decide whether to approach this patient with endocrine or hormonal based therapy or chemotherapy, you have to kind of step back and think about the biology of this disease. Next slide, please. So once you know someone has metastatic disease, the goal of treatment is to keep them alive longer, obviously, but mostly to improve their quality of life. So if you remember rounding with me, I'm always looking back at the beginning. Where was their disease? What were their symptoms? How have we helped them, or have we helped them? So next slide. And to make the diagnosis, this is out of our Butaro protocol, to make the diagnosis of metastatic disease, it is metastatic if it meets any of the following criteria. Distant disease, as in the bones, liver, lung, brain, or skin distant from the breast, cervical lymphadenopathy, or any contralateral lymphadenopathy. And it's really important to think about biopsy, although it's really hard to do in Rwanda, and I realize that. If it is an issue of contralateral lymphadenopathy, that would be feasible. We could do an ultrasound guided biopsy of a lymph node on the contralateral side to prove that this is metastatic disease and not some sort of granulomatous process, and to get receptors again to make sure that it's ER positive or ER negative. And based on my last trip, we're finding evidence that interventional radiology and the capacity to do CT guided biopsies is getting closer in Rwanda and may be available in the next few years, which is very exciting. Next slide. And using the tools we have available in Butaro is very difficult to make a firm diagnosis of metastatic disease. And I think we looked at several chest x-rays. Every time we're there, we're looking at chest x-rays. And to make a diagnosis of metastatic disease by chest x-ray is really challenging. And I think especially when there could be other things going on. So you have to think about what else could it be if it isn't metastatic disease? Could they have granulomatous disease, giving them hilar and mediastinal adenopathy on the chest x-ray? Could it be liver cysts or infection that is happening that we're seeing? Because to give somebody the diagnosis of metastatic disease is obviously a big change from cure to incurable. So you really want to be pretty sure. And I feel like on chest x-ray, if that's the only abnormality is some hilar adenopathy, I would be very careful about giving them the diagnosis of metastatic disease. Next slide. So principles to guide therapy, knowing their ER status is really important. I know that's been challenging of late because of stockouts of the reagents for immunohistochemistry. So as soon as possible, try to identify whether it's ER positive or not. And even if they have widespread metastasis, liver mets, bone mets, but they're tolerating it reasonably well and overall functioning well, then starting with estrogen-based therapy is perfectly appropriate. And tamoxifen or letrozole can be used depending on their menopausal status. If it's ER positive, but they have a very high tumor burden and are symptomatic, so long mets giving them hypoxia or shortness of breath, pain in the bones, or liver function problems where their LFTs are abnormal, or they have hepatomegaly or visceral pain, that's where chemotherapy can really help reduce the symptoms a little more quickly. If it's ER negative, then we really only have chemotherapy available. And what to use depends on how long it's been since their first diagnosis and what they were treated for before. Next slide. So ER positive, you want to think about how sensitive is it going to be to tamoxifen or letrozole if you're choosing that for your first treatment approach. If it's been less than 6 months from their first diagnosis of breast cancer, the first question, are you sure these metastases are new? If you think they might have been there before, it's perfectly fine to leave them on whatever they're on now. So if they're on tamoxifen and they're becoming symptomatic, but you think they might be responding, you can follow it a little bit longer to confirm to yourself whether they're responding or not. And you may need at least 2 time points to know if the disease is getting worse on current therapy or not. If it's clearly progressing on whatever they're on, then changing to letrozole or tamoxifen would be the next step. If they're premenopausal, it's important to remove their ovaries surgically, and then they can use either tamoxifen or letrozole. Next slide. So the goal of therapy in ER-positive metastatic disease is to deplete the body of estrogen because it's a potential fuel for growth of any cancer deposits wherever they are in the body. And although ovarian production of estrogen disappears with menopause, postmenopausal women continue to produce low amounts of estrogen in their fat cells, in their liver, in their adrenal glands. And this estrogen is derived from adrenal precursors such as testosterone and androstenedione that are converted to estradiol and estrone by aromatase activity in the peripheral cells and even in the cancer cells themselves. So that's where the principle of an aromatase inhibitor like letrozole comes from, because it can stop that estrogen production wherever it's happening in the body. Next slide. So just to review some of the advances that are happening in countries with access to more than letrozole, because hopefully these will become available in Butaro at some point. I thought it would be good to give some overview of that. So letrozole and anastrozole are very similarly based drugs. They're azole compounds, and using them by themselves, one or the other, metastatic disease allows for a progression-free survival time frame of about 6 to 10 months for most patients before they develop resistance and might have to go on to something else like chemotherapy or tamoxifen. In the US, we also have exemestane, which is an aromatase inhibitor that's a 17-hydroxysteroid. And you can sometimes get responses after progression on letrozole by switching to exemestane. Tamoxifen is a selective estrogen receptor modulator, and there are also a class of drugs that are downregulators of the estrogen receptor that can be used, such as fulvestrant, and that's an intramuscular drug that's given every month. The more recent developments in the US and in other countries that have access to these drugs have identified additional targets, such as the CDK4/6 inhibitor, which when combined with an aromatase inhibitor extends progression-free survival by doubling it. So instead of 6 to 10 months before resistance develops, people can stay on that combination for 10 to 20 months. And longer. So that was on average. And in my practice, I see people on these combinations for many years without progression. We know now also that if a PI3 kinase mutation develops, then people will respond to a combination of letrozole plus a PIK3CA inhibitor. And those are recently FDA approved. And an older combination is exemestane plus everolimus, which is an mTOR inhibitor, another pathway of resistance that if you block that in combination with aromatase inhibitors, extends the period of time that folks can stay on a hormone-based treatment. Next slide. So resistance is pretty inevitable. I think if you have an ER-positive metastatic patient and they've developed lesions either while on adjuvant therapy or on first-line metastatic disease, it's clear that resistance to this estrogen approach has developed. And the reason biopsies are important is because in that process of resistance, the tumor can change and can often lose its estrogen receptor positivity, or in the setting of some of the ER negatives, they can gain ER receptor positivity, in which case you then have a change of treatment that is different from the way the primary tumor was treated in the first place. So increasingly, as technology advances in Butaro, it's important to think about getting biopsies of the metastatic disease whenever possible. And we often will know their HER2 status, even though we don't have HER2 targeted drugs. And you may wonder why that's important. I think it is important because it is a marker for a tumor that is more likely to develop resistance to estrogen blockers in a shorter period of time. So if it's ER positive, HER2 positive, and you're starting with an estrogen-based approach, you want to make sure you're checking for resistance a little more often, perhaps, than you might if they were HER2 negative, because you want to make sure you're catching that progression, ideally before it causes life-threatening disease. And that might be a time to move to chemotherapy a little sooner. So whether or not to try a different endocrine agent after progression or to move to chemotherapy, again, depends on the biology of the tumor. And if you have the ability to biopsy, then you want to look at the relative level of estrogen receptor in the cancers. Is it less than 10% positive or greater than 10% positive? And often we'll go and sit down with our pathologist and look at that to decide whether it's still strongly sensitive to an estrogen-based approach or not. Alternatively, if you don't have a biopsy, you can go back to the primary tumor and look at it and review it and decide whether you want to go to chemotherapy first or not. The duration of response to first-line therapy is important. If somebody has been on letrozole for a year or two before they get symptomatic, again, from resistance, they're likely to respond to tamoxifen again for another, ideally maybe 6 to 12 months before they progress and need chemotherapy. If they didn't respond at all to letrozole, they're very unlikely to respond to tamoxifen, and it makes sense to go to chemotherapy next. Side effects to treatment are also important, although I've rarely seen anyone in Rwanda complain about side effects from letrozole. But if they do, such as joint pain, then that would be a reason to switch to something else as well. Or if they have rapidly progressive disease and are clearly symptomatic. Next slide. And it's really not a good idea to combine endocrine therapy with chemotherapy. And if you think about the biology of that, endocrine therapy or letrozole or tamoxifen is converting cells out of their growth mode by blocking that estrogen influence. Chemotherapy works on actively dividing cells, so you want them in their growth mode if you're giving them chemotherapy. So you want to do them separately, not together. And studies have looked at this, and there's really no improvement in overall survival by combining them. And it actually, because of that biology effect, it may actually decrease response rates. Next slide. So if they have extensive visceral metastases, their lungs have multiple tumors bilaterally, their liver is dysfunctional, you want to think about which chemotherapies to use. And so end organ dysfunction is defined as pulmonary metastases with shortness of breath, liver metastases with elevated liver function tests. But you do have to use caution if their bilirubin is elevated as well. And generally we use a bilirubin over than 3 or higher than 3 to determine whether they need a dose reduction or can't have chemotherapy at all because the liver is unable to process it safely. If you're going to start with chemotherapy first, then that will maximize the chance of a rapid response. And if it's ER positive, you want to think about converting over to endocrine therapy as soon as possible to minimize the toxicity. And generally 4 to 6 cycles of Taxol, for example, is a good ballpark to think about. If you can improve their symptoms in that time frame, then you can switch to letrozole and maintain that response, hopefully without the added toxicity. Next slide. So if they've already had treatment in the early breast cancer setting, then you have to think about what they've had before and what are the chances of response to the next line of therapy. If they have liver dysfunction, paclitaxel can be given without dose reductions unless the bilirubin is really high and there's evidence of obstruction. Anthracyclines can also be given, but you do need to think about a dose reduction. And single agent chemotherapy will generally have response rates of 30 to 40%. If they've previously had chemotherapy within 6 months, let's say they just finished their ACT in June and now it's December, it looks like they have liver metastases, they're very unlikely to respond to Taxol at that point. And I would use 5-FU first. If they've only received AC in the adjuvant setting, then Taxol is still a potentially very active drug and should be used first. If they have neuropathy from the adjuvant paclitaxel that they had before, then you could consider doxorubicin first, which generally doesn't have a lot of neuropathy. And as you all are pretty well aware, the anthracyclines can cause heart problems. If they have swelling, then make sure an echocardiogram is done to check their ejection fraction. But if you're worried about their heart, then I would use paclitaxel, not an anthracycline, or 5-FU, which are both safe in heart failure settings. Next slide. And finally, I think it's really important to start thinking about conversations about palliation and even end-of-life care. So are we helping the quality of life, or are we potentially harming with the chemotherapy that we're giving? Or are we just not helping? You know, where I've seen people on Taxol for long periods of time, and it's kind of unclear whether it's doing anything at all. They're not suffering from it, but there's harm in the fact that they keep having to come, and that it sets their family back. They have to support the patient while they're there. So think about, is it helping or is it potentially harming in some way? And this also is from our Butaro protocol. So treatment in this setting is not curative, but will aim to ease symptoms and prolong life where possible. Start treatment if the patient has a performance status of 0, 1, or 2, or if symptomatic. And liaise closely with colleagues in palliative medicine to assist in symptom management, psychosocial support, and transition to end-of-life care. And I think we'll go into this in the slides ahead of us, but it's important to think about how to start that conversation as soon as you're giving somebody a diagnosis of incurable breast cancer. Next slide. So we talked about biopsy, and I think as this becomes more available, it's important to think about because you really need to be sure. And I feel like increasingly there was some doubt as to whether the CAT scans were accurate in terms of liver metastases or lung metastases. And if there's any doubt, the safest thing is to start treatment and then repeat the imaging in a short period of time to see if there's response or not. Next slide. And also, it's also important as we see young women showing up with metastatic disease to discuss family planning and really try to avoid pregnancy during any kind of chemotherapy for any kind of cancer, really. I saw some gaps in whether or not the contraception method was identified in the chart or whether pregnancy was tested for before chemotherapy was given. So be sure to talk about it, ask about their contraception method, document whether they're pregnant or not, and check periodically, ideally every 2 or 3 cycles, if they're still of reproductive age. Next slide. So just straight out of the protocol, I just thought I would review there. We don't need to go through this line by line, but I want to make sure that no one has questions about how this talk might mesh with the protocol or any questions you might have that have developed as you round on patients. Very important to make it clear to patients that treatment in this setting is not curative, but is aiming to improve quality of life. If we're able to achieve stable disease, that's a good response. And clinically, that usually is associated with a clinical benefit in symptoms. The performance status is really important, especially if they're developing bone metastases or disabling symptoms. If they're unable to walk in comfortably, or can't get out of bed for whatever reason, they're really unlikely to benefit from chemotherapy. And it's important to start the conversation about when do we have to stop treatment because we're not helping anymore, and helping the family adjust to that. Psychosocial support, end-of-life counseling. The sooner you start talking about it, the easier it is to make that call whether or not treatment needs to be stopped. And it does need to be stopped when there is clear evidence of disease progression or when the burdens or receiving therapy outweigh the benefits. And this should be assessed every 2 cycles to determine the risk-benefit ratio. Next slide. So to review what we generally do in Butaro, so in patients who have metastatic disease at the time of presentation, single agent paclitaxel is a perfectly appropriate place to start. It's usually done every 3 weeks until disease progression. If a patient lives nearby, it's actually been proven to improve survival to give it weekly as opposed to every 3 weeks. So that's something to think about if it's feasible for somebody who lives nearby. Doxorubicin every 3 weeks up to the maximum tolerated dose of 450 milligrams per meter squared is also a good second-line option. And weekly dosing can be considered as well. There's no survival benefit, but it can be better tolerated if there's liver dysfunction or other symptoms. 5-FU can also be given either weekly, or I think the way we generally do it in Butaro is every 2 weeks with the continuous infusion over 2 days. Next slide. If they've developed metastatic disease more than 12 months after ACT in the adjuvant setting, you can re-challenge with Taxol until disease progression, then 5-FU, and then consider doxorubicin. But at each transition, it's important to talk about the risk-benefit ratio. What is their quality of life? What have we achieved? And how taxing is it on the patient and the family to continue treatment? Next slide. If it's less than 12 months after ACT, then I would start with 5-FU and then consider doxorubicin. But again, you have to think about the maximum dose. There are some situations in metastatic disease, if they have a dramatic response to doxorubicin, that you can go above the maximum, but I would be careful about that and discuss it with us on the calls. Next slide. If it's stable or decreases after about 6 to 9 months, you can often give a drug holiday. I think you guys are pretty familiar with that. And then have them come back when symptoms develop again. The idea of surgery comes up from time to time. And there's generally kind of a short window for that. I've seen it in triple negative cases, or there was a case a couple weeks ago of a Paget's disease where it was very locally invasive around the nipple areolar complex. And the surgeons were willing to do a palliative mastectomy in those settings, but it's pretty limited access just because they're busy doing curative lumpectomies or mastectomies. But something to think about, and it never hurts to just get a surgeon involved to see if they may be able to help when, especially when there's really locally advanced ulceration or bleeding going on. Next slide. So brain metastases comes up from time to time where they have central nervous system symptoms or side effects. And it's just important to know what the approach should be. I think it's rarely feasible in Butaro, but if you do identify solitary or 1 to 3 brain lesions, and it's been a long time since their first diagnosis, first of all, consider other diagnoses. Could it be toxoplasmosis or primary CNS lymphoma or something like that? And then inquire as to the feasibility of neurosurgery and or radiation, depending on their resources and their access to higher levels of care. But if they've had a long time since their first diagnosis, you can get good control for another several years with radiation or surgery. If they have multiple lesions, then whole brain radiation is an option. The access for that will depend on the access to radiation in general, which, as you know, is rapidly increasing, thankfully. But whole brain radiation does have side effects, including memory difficulty, lower cognitive function, and increasing fatigue. These risks are increased if they have other comorbidities like hypertension, diabetes, or vascular disease. Next slide. Monitoring therapy during metastatic disease is really, really important, and checking every two cycles or so, what were their symptoms when they presented? How have we improved them? Have we improved them? What things have been getting worse, or what challenges do the patients have during these treatments? Make an assessment whether it's helpful or not. And if given the resources we have in Butaro, I also would think about, if they've had a CAT scan that shows pulmonary lesions, get a chest x-ray at the beginning so that you can compare apples to apples more easily given the resources available in Butaro. So if you can get a sense for what the chest x-ray looks like, you can tell whether things are responding or not. If the nodules are not visible on chest x-ray, that won't be helpful. But if they are, it can be very helpful to track response. Similarly, if they've had a CAT scan and there's concern about liver disease, an ultrasound, now that we have bedside point of care ultrasound technology available, getting a baseline with the resources available is really helpful for monitoring. And I would encourage you to use the resources you have to make your best assessments. Next slide. Duration of treatment really depends on symptoms and et cetera. So if the estrogen receptor is unknown, and a lot of those have been unknown lately, starting chemotherapy is appropriate, but ask for estrogen receptor testing as soon as possible, and that you can work with DAO to prioritize that. If they're already ER positive and you know that, then consider endocrine first if their symptoms are minimal, or start chemotherapy, but then switch over to tamoxifen or an AI. And if they're ER negative, continue chemotherapy until progression. Next slide. For brain metastases, there's really no survival advantage to chemotherapy if that's their only site of disease. And other studies have looked at different types of chemotherapy that might cross the blood-brain barrier better. But generally, they do sometimes see better response rates, but there's no survival advantage. Next slide. In the US, median survival is definitely increasing for metastatic breast cancer due to more effective treatments, aromatase inhibitors in combination with CDK4/6 inhibitors and other targeted agents, taxanes, and the HER2 positive drugs. And our hope is these will soon be available in Butaro. Next slide. this is somewhat repetitive. So I think we covered endocrine versus chemotherapy for visceral disease. We can move to the next slide. And combination chemotherapy sometimes can increase response rates, but there's really no difference in overall survival. So, you know, if you know they have metastases, there's really no benefit to doing AC or AT combined. And the toxicity is significantly higher. Next slide. Anthracycline-based combinations, again, higher response rates, but no change in overall survival. Next slide. We do have access to non-anthracycline combinations in the US, gemcitabine with paclitaxel, capecitabine oral, which is oral 5-FU plus taxane, or an ixabepilone, which is a microtubule inhibitor. Sometimes we'll use CMF, which is cyclophosphamide methotrexate 5-FU, or platinums, but carboplatin was equal to docetaxel and somewhat superior if you know they have a germline mutation. So things to think about as additional chemotherapy gets available in Butaro. Next slide. And finally, just approaching difficult conversations, and I'd be interested to hear more from you guys about this topic, because I think it's hard for me, not knowing the language, to know what happens when we are telling someone we have nothing else to offer them. So for example, a 40-year-old mother of 2 young children has metastatic breast cancer. She's had 4 cycles of doxorubicin already. Her mass is getting worse. Her doctor is discussing second-line chemotherapy, such as Taxol or 5-FU. Is it appropriate to talk about palliative care now? And if not now, then when? When is the right time? Next slide. It's important to think about prognostic and predictive features. What are the chances she'll respond to this second line? Would it be appropriate to move to a third line in that case? And eventually we'll get to the end of the line, right? And so that needs to be part of the conversation too, to help them adjust to the idea that at some point she's going to die from this disease. Next slide. There's an interesting concept in an article that I shared last year, hoping for the best, but preparing for the worst. And that's one way to approach the conversation. And again, I'd love some input from the Butaro staff on how feasible you think this is. Can you discuss, you know, hoping for the best in terms of response, but knowing that eventually we will reach the end of life, and how is that going to be addressed? What psychological, spiritual, and emotional issues are going to arise for the patient and her family, and how can we help them with that? Next slide. And I think as you approach these conversations, the best way is to try to give equal time to being hopeful, but also, you know, realistic, I guess, in terms of planning. And you can take time to read through this a little bit on your own. Next slide. So in summary, metastatic breast cancer means lifelong treatment, but also, unfortunately, that this patient will most likely die within 1 to 2 years. I think it's important that you have confidence in the CAT scan results before you give someone this diagnosis. Always start with the least toxic treatment available, and make sure you know what the endocrine or the estrogen receptor status is. When in doubt, repeat studies within a few months to confirm whether or not things are responding to the treatment. Know where the disease is at all times and strive to determine whether the treatment is helping or hurting. And approach discussions regarding end-of-life care early. It's an ongoing discussion and important to involve the family if they are able. Thank you very much. And I'm really looking forward to questions and conversation if people have time.
Mary, the team in Rwanda just had a huge clap for you. I don't know if you heard it.
Oh, no, I didn't, but thank you.
So Kevin, Nikas, do you have any questions or comments from anyone? Thank you, Mary, for the presentation.
You're very welcome.
Yeah. So thank you, Dr. Mary, for your good presentation. It's very instructive and educative. So my question is about cumulative doxorubicin. Can you explain more? Because sometimes we don't understand very well about cumulative doxorubicin. So suppose that someone is metastatic, get doxorubicin and improve well, and survive over X time, and there is recurrence, and you know that he did well with doxorubicin. Maybe after 2, 3, 4 years, can we repeat doxorubicin, or only we can't repeat doxorubicin? That is my first question.
Mm-hmm.
Second question is about suppose we have many patients who come with metastatic. We know our region, our countries. People came sometime with metastatic disease. Suppose a young woman, very young, 30 or 35, came with cancer metastatic. She has biological ER is positive, highly positive, 100% or 90%. Is it better to, can we do oophorectomy and tamoxifen at the same time, or tamoxifen can be only the best one? Thank you.
Okay, thank you, Nikas. Great questions. So the doxorubicin topic. So first of all, I think the maximum dose concept is for people being treated for curative conditions, first of all. And so for example, somebody who might have had Hodgkin's disease when they were 25, and now they're 45 and they have breast cancer. You need to know what amount of doxorubicin they might have had during their previous cancer treatment, so that you're not putting them at risk of yet another problem. In the breast cancer population, it's a little bit more difficult to define what is the limit. And I think the bottom line is, how is their heart function? If they have heart failure problems from HIV or from, some other problem, then anthracycline of any dose is not a good idea. If their heart is healthy and they have metastatic disease and they've responded well to doxorubicin, and that you continue to see a response, then it's okay to push toward that maximum dose limit, and even sometimes exceeding it if they continue to have visible response, not just stable disease. And again, I think that's a very careful situation. But I have personally had a young woman who had a really dramatic response to doxorubicin, and I, kept it going quite a long time, because that was really the only option she had for a good response. But you have to do periodic echocardiograms and monitor closely for heart failure symptoms. Because, if you think about it, their breast cancer is their most life-threatening condition, not the risk that they could develop heart failure if they're going to die of their breast cancer first. Right, but I think the 450 maximum is a really good limit, because usually in Butaro, you're going to get a maximum response from doxorubicin within that limit. And I that's where monitoring response is really, really important. So if you're approaching that limit, that's a really important time to come to the call and give us all the information so we can guide you of whether or not it makes sense to go above that limit or not. In terms of the ovarian suppression question, I think in young women with ER positive metastatic breast cancer, it does make sense to do oophorectomy, because then you can use either tamoxifen or letrozole. I think you can use, depending on the timing. So if they come in and they're very symptomatic, you want to start things as soon as possible, start tamoxifen, then set them up to see surgery, have their ovaries out. If they're responding to tamoxifen, you can continue that as long as they continue to respond to it. Then you have the option of switching to letrozole. If they've progressed on tamoxifen already, but before they had their ovaries out, they still might respond a little bit more once their ovaries are out. So I think you just do it based on increasing your options for treatment for these young women. Does that make sense?
Yeah, very good.
Okay.
So, but I have another short comment, not a question, but a comment. In our area, so we don't have a many surgeon, of course, but there is many cases, patients who come with metastatic, but when you look on the breast cancer, they should come when the patient, when you evaluate clinically, while patient is still able to be operable. So, but when it is metastatic, you have a habit that you don't operate those patients. So, but when you look in the community, when there is a progression of the disease, really it is very high, can I say, harmful for even community environment. How do you think? I think we should operate for some patients who really are metastatic, just to improve quality of life and maybe to yes. So I don't know if you catch what I want to mean.
I think I know what you mean. I mean, you're talking about palliative mastectomies for local control.
Okay, I didn't catch you. Yeah.
I think I understand. You're saying you think there could be more people who could benefit from breast surgery even though they have metastatic disease.
And, yeah, sure. Yeah.
And I think you're right, but I think it's an issue of limited access, and that's why involving the surgeon, if they're able to do it, I think he will do it, if he has the room in the OR, but I think also it's helpful to know how things are responding first. If they have a dramatic response to chemotherapy, they might progress in the liver before they ever progress in the skin and need local control. So it's case by case, and it never hurts to ask the surgeon, could you consider, so that they don't have to deal with this oozing, ulcerating mass at some point if possible. But it's also been shown to not necessarily provide any survival benefit, and that's the difficult part.
Yeah. Thank you so much.
You're welcome. Are there any other questions?
Yeah.
Yes. Hi, Dr. Chamberlin, it's Kevin.
Hi. Hi, Kevin. How are you?
Hi. Good. One quick question I had. Is there any indication, if you have like an oligometastatic lesion, like an isolated liver lesion, is there any indication for surgical removal at that point in terms of survivability, or once it's metastatic, that's contraindicated?
Yeah, that's a great question. So, in other cancers like colon cancer, there is a benefit to limited liver resection for isolated metastases. In breast cancer, historically, there hasn't been a survival benefit. However, as we're improving in our systemic treatment options, that is changing, especially for HER2 positive disease or slow growing ER positive disease. So in a case like that, it really depends on the time frame from first diagnosis to the development of metastases. So it could be considered if there's very limited one liver lesion and no sign of disease anywhere else. In Rwanda, there's no support for liver resections. And we just talked to a surgeon in Kigali about that last week. They don't have the ability to support somebody with the appropriate blood supply, anesthesia, etc., to do any kind of liver surgery. But in higher level settings, you could consider liver surgery and or liver directed therapies with radiofrequency ablation or sometimes chemoembolization to isolated liver lesions. So it's whenever there's a situation like that, multidisciplinary conversation with surgeons and radiation oncologists, radiologists, medical oncologists is really important.
Thank you. That's helpful. Thank you.
You're welcome.
So, thank you, Dr. Mary. I think is no other question in the audience. Thank you so much.
Hey, you're very welcome. Great to see you guys. And welcome, Kevin, to Butaro.
Thank you. It's been great.
We'll see you soon.
Thank you so much, Mary.
So,
You're welcome.
If we don't have any other comments, questions, hi, Becky. We can call it a day.
Okay. Till next time. Have a good day.
Yeah.
okay.
Yeah.
Bye.
Thank you. Thank you. Bye.
Have a good day, everyone.
We can